Differentiating radiation necrosis from tumor recurrence. Do we need hybrid imaging? That is the title of this lecture, and the topic may seem a bit narrow, but it is important because we have an increasing number of patients receiving radiation and chemotherapy after surgery, patients with malignant brain tumors, usually gliomas or metastases, and in many of those cases we have a clinical problem to differentiate between recurrent tumor and post-therapeutic changes, and that's what I will talk about in this presentation. The outline of my talk is first a short background about the topic, then I will go into the different methods that we can use to help us to improve this diagnosis and the differential diagnosis, and finally I will show some clinical examples. Treatment follow-up after surgery and radiochemotherapy is done in patients mainly with gliomas and metastases, and the treatment can be followed, of course, with the clinician's evaluation of clinical symptoms and clinical findings, but we radiologists play also an important role because there are frequent follow-up imaging scans, and for that we use in the clinical routine MRI with and without contrast injection, including diffusion weighted imaging in the routine. We would, in cases with gliomas, always add perfusion MRI. We have MR spectroscopy that can be used as an additional tool. PET is a really good additional tool to help us, and maybe we could use the combined scanning with PET and MRI in a hybrid scanner. Treatment-related changes may occur early or late. The early changes appear in less than 3 months, sometimes up to 6 months after the treatment with radiation and concomitant temozolomide in patients with high-grade gliomas, and then we call it pseudoprogression. These are reactive changes and are seen in 10 to 30% of these patients. The histopathological background is increased vascular permeability, edema, necrosis, and the changes are reversible. On MRI we see the increased size of contrast-enhancing lesions, and they usually have a mass effect. The late effects appear usually about 9 to 12 months after treatment, but they can occur up to several years after the treatment, and these lesions we call radiation necrosis. They are seen in 3 to 25% depending on radiation dose, treatment duration, etc. And in cases with the metastasis treated with stereotactic radiosurgery, they can be seen in a higher frequency due to the higher local radiation dose. They are caused by vascular injury, demyelination, edema, and necrosis. And on MRI we see high T2 signal intensity, initially some mass effect followed by volume loss. The contrast enhancement is usually a bit different from the one we see in tumor recurrence, but not at all always, but we have often a soap bubble-like appearance or sometimes a Swiss cheese appearance of the enhancement. Occasionally it can be ring enhancing, and in many cases it looks just like tumor recurrency. Before I go into the different methods, I will show you an example with some images where it was difficult to differentiate between tumor recurrence and treatment-related changes. This patient was operated for an anaplastic astrocytoma in the left frontal lobe 3 years ago. You can see here the post-operative cavity on the T1 weighted image without contrast injection, and this is the post-contrast T1 weighted image. I have given you here 4 alternatives that you can think about. This is not a real quiz, but you can think what you would presume to be the most likely diagnosis. Could it be tumor recurrence, reactive treatment-related changes, both, or maybe you don't know at all? and I must admit I don't know either, because we just have these images. So we need to add some other tools to help us. We performed a fusion MRI with calculated RCBV maps. Here you see the postoperative cavity. The red and white is hyperfusion, high RCBV, which is seen in the cortex and also in large vessels, and it's really difficult to evaluate in this region because we have so many large vessels here. And this region where we had the other lesion medial to the occipital horn of the left lateral ventricle is also very close to the cortex, difficult to evaluate. So we added a methionine PET scan, and here we are helped a lot, because you can see in this anterior temporal lobe lesion we have a low uptake, and in the lesion medial to the occipital horn the uptake is very high. So in this case it was a combination. This lesion was reactive and the other one was recurrent tumor. So the correct answer is both. Does perfusion MRI add information? In recurrent malignant brain tumors, we see a high relative cerebral blood volume with a ratio to normal appearing white matter, usually in the contralateral hemisphere, about 2.5 or higher, and these cutoffs, they vary in different studies, different scanners, but this is quite a good cutoff that you can use. You also see high RCBF on DSC, and on the DSC you should always use the leakage corrected maps, because otherwise the findings could be completely misinterpreted. The post-therapeutic changes have low RCBV and RCBF. The perfusion MRI has around 75 to 80% accuracy, reported in different studies to differentiate between recurrent tumor and post-therapeutic changes, but in practice it is not always so easy. First, the method is not used by everybody, it is not so widespread in clinical practice, and I would highly recommend that you use perfusion MRI in all patients with glioma, both primarily and for the follow-up evaluation. Then the standardized protocols and post-processing is not always present in different clinics. There are also artifacts in the form of signal loss from blood products and metal in the DSC perfusion, and that is of course commonly present in patients who have been operated upon. DCE, that is dynamic contrast enhanced perfusion, the T1 perfusion, or arterial spin labeling, ASL, they have less susceptibility artifacts and they can be used instead, but they are less established in the clinic than the DSC perfusion, and they take a little bit longer time to perform. It is also difficult close to the cortex because, as I showed you, we have high perfusion in the cortex. The next method I will discuss is the MR spectroscopy. In recurrent malignant brain tumor, we have a high choline peak, and the choline to creatine ratio is usually above 1.4. You have a low NAA peak, and in radiation necrosis, you have low choline to creatine ratio, and increased lactate. Of course, you can see increased lactate also in the brain tumors with necrosis. The spectroscopy has not a widespread clinical use, and it takes some time to perform. The greatest disadvantage in this context is, I think, that it is very sensitive to magnetic field inhomogeneity, which means that artifacts close to post-operative cavities can disturb the evaluation. And often the contrast-enhancing lesions that we see are small, and then it is difficult to obtain selective spectra without partial volume. And we usually use the spectroscopic imaging, the MRSI, with a resolution of 0.5 to 1 centimeter, which is then covering usually also some normal brain tissue. What about PET? Can we use that as an additional tool? I think PET is really good, but you have to select the adequate tracer that is most useful for this purpose. If you use 18F FDG PET, that is fluoride deoxyglucose PET, which is reflecting the glucose metabolism. You have an increased metabolism in malignant tumors because the tumors use glucose to grow, but the negative aspect of this is that you have also high metabolism in normal brain, and therefore it is difficult to delineate lesions with high uptake, with this surrounding high uptake. However, we have the amino acid tracers, for example, carbon 11, methionine, or fluoride 18, fluoroethyltyrosine, which is a tracer with a longer half-life. The methionine tracer has a half-life of 20 minutes, and the fluoride the half-life is 109 minutes, so it's much more useful. You can also transport a tracer, and you can use it in clinics without the cyclotron in the hospital. These tracers pass through an intact blood-brain barrier, so you have uptake also in low-grade gliomas, but lower than in high-grade gliomas. You have high uptake in malignant tumors, that is in high-grade gliomas as well as in metastases. You have low uptake in reactive changes, and you have a standardized uptake value, the so-called SUV, maximum in the lesion ratio to the SUV mean in the reference region, which is usually lower than 1.5 to 2, but these cutoffs can vary between different scientific studies, different scanners. So the disadvantage with these tracers are that they are not specific for neoplastic tissue. They can also occur, the high uptake can also occur, for example, in abscesses, but this is usually not a question. So we know that we have the differential between the tumor recurrence and the reactive changes. Some examples. This is a woman, 64-year-old, who had a previous surgery for a glioblastoma. You see the resection cavity here in the right occipital lobe, and she was treated with radiation and chemotherapy. Now there was a new, very small contrast-enhancing lesion at the border of the resection cavity 8 months after radiotherapy. And this is seen here on MRI in the coronal view as well. It is just inferior to a choroid plexus cyst, which makes the evaluation more difficult. A perfusion MRI was done, but not so easy to interpret, and therefore we added a methionine PET. This was 1 month after the MRI, so you can see here that this shows a very high uptake in the lesion, which supports the fact that this should be recurrent tumor. Then the patient was planned for surgery to remove this lesion, and the preoperative MRI performed 1 month after the methionine PET showed, unfortunately, progression of the tumor, which was, of course, confirming the diagnosis, but it would have been better to perform the PET in very close proximity to the MRI, of course, and then to do the surgery without delay. My second and last example is a male, 76 years old, who had surgery for a glioblastoma in the left temporal lobe. You see the postoperative cavity here on these slices without recurrence. These are just reactive changes. And 9 months after radiation treatment, there was on MRI a new contrast-enhancing lesion here in the medial temporal lobe, which was above the resection region. You also had signal changes on FLAIR. Then we performed the perfusion MRI, and the RCBV was not increased in the lesion. As you can see here, there is no high RCBV, and the methionine PET showed an uptake that was not very high. The SUV ratio was 1.8. So what would you think about? You could probably conclude that it probably they are reactive changes. We also performed the spectroscopy, where you can see the MRSI here within this blue square. You have a spectrum from each of these small regions. This is the lesion, and here you can see the choline, creatine, NAA range of the spectrum, where you can see that the choline peak is not very high in the lesion, which supports that this is probably not malignant tumor, so we consider this to be reactive changes. Radiation necrosis. The patient came back 1 year later. This is the image I showed you previously, where we have this lesion and the uptake that was not very high. At this time we did MRI with progression of enhancing lesions, new lesions. The perfusion was now high, which it was not before, and we didn't perform methionine PET because now it was regarded as a recurrent tumor clearly, and probably combined with some reactive changes. So we think this was a combination, previously reactive changes and now also recurrent tumor. So the combination of MRI and PET could improve the accuracy, but of course if you have a hybrid PET-MR scanner, a one-stop shop is good for the patient and prevents treatment delay due to the waiting time from MRI to PET. But it is of course cheaper to add PET when needed and then co-register with MRI, because you don't need PET in all cases, but PET is a really useful tool when you are uncertain about the differential diagnosis. So my take-home message from this lecture is that it is not easy to differentiate radiation necrosis from treatment recurrence, and because of that we usually avoid MRI within the first 3 months after radiation treatment. If the symptoms are stable, of course you need to do it if you have increasing symptoms. And in the practical routine we perform MRI with and without contrast injection for the further follow-up, and we always perform MRI perfusion with the DSC technique with calculated RCBV maps with leakage correction. In the difficult cases we add amino acid PET without delay and try to co-register the images, which is rather easy because the brain is not moving. So, but if you have PET MRI and it is easily available, of course you should use it. MRS can sometimes add further information. And one more important point that you always should remember to compare with the clinical findings and the timing of the treatment. You should always know what the treatment, which treatment the patient received and when to relate it to the findings. So thank you very much.